Welcome back to Mayo Clinic Radio. I'm Dr. Sanj Kakar.
And I'm Tracy McCrae.
You've probably experienced it, feeling so tired you can barely function at work or school because you didn't get enough sleep. Insomnia is a common sleep disorder that can make it hard to fall asleep, hard to stay asleep, or cause you to wake up too early and not get back to sleep.
In fact, insomnia is perhaps the second most common health complaint after pain. It's estimated that 15 to 30% of adults suffer from insomnia. So how can you improve your chances of getting that good night's sleep? Here to discuss treatment for insomnia is Mayo Clinic psychologist Dr. Craig Sawchuk. Welcome back to the program, Dr. Sawchuk. It's good to see you.
Great. Thank you for having me back.
First of all, I thought that insomnia, we would have one of our sleep experts, not the psych guy. How is insomnia a psychological problem?
Well, I tell you, the behavioral psychologists have had insomnia figured out in terms of a very effective treatment for it for several decades. It's actually only been until more recently that the American College of Physicians identified cognitive behavioral therapy for insomnia as the first-line treatment for insomnia disorder and insomnia-related problems. And that's actually a big deal coming from a physician group where traditionally sleeping medications are unbelievably frequently prescribed and have short-term effectiveness at best.
So Dr. Sawchuk, many people vary in how much sleep they need. Some people 3 to 4 hours, some people 8, 9 hours. So how do you define insomnia?
Yeah, insomnia is not really based upon, well, how much sleep did you actually get? You know, it's not about sleep quantity, it's more like quality. So when we drill down to exactly what is insomnia, it's 3 days out of a given week over the course of 3 months that you have some problem with either sleep initiation, so the classic sleep onset, I'm laying in bed trying to fall asleep and I can't sleep, or that fragmented shallow sleep during the night, waking up a lot during the night and then having difficulties falling back asleep, or early awakening. So it's any one of those three that in turn leads to the non-restorative sleep and in turn can cause some problems in day-to-day functioning.
Is there a typical patient who suffers from insomnia, men, women, or the age?
It is so equal opportunity. Just usually like sleep needs change, you know, as time goes along and our patterns do change, but it really is an equal opportunity type of condition that can affect anybody at any time. But almost regardless of where the insomnia comes from, it doesn't matter. It's how insomnia is being maintained, and that's how behavioral therapy can be effective in managing that.
So what are the risk factors for insomnia? So for example, many people look at their emails before they go to bed or watch TV. Is that a good thing? Is that a bad thing?
It's a bad thing, and good thing Dr. Shives isn't here today. He gets a little upset about the use of electronics and,
Yes,
and iPhones. But it's true. You know, the reality is that the vast majority of people have absolutely horrible sleep habits, hygiene habits. They'll watch TV in bed, they'll eat in bed, they'll hang out in their bedroom, you know, just to rest. Or if they wake up in the middle of the night, they may just keep laying in bed, you know, awake. But the people that those people don't necessarily go on to develop an insomnia problem. It's the people that have true clinical insomnia that we actually have to look beyond just the sleep hygiene related issues. They're still important to have in place, but there's some much more important components to treatment than just sleep hygiene.
I love the phrase sleep hygiene. Can you expound a little bit on that and what it means if someone's hearing it for the first time?
Yeah, the classic thing, think about them like healthy sleep habits. And we hear about these things all the time. It's good to be in a dark, quiet, cool room, reducing electronics and ambient light, trying to maintain a good sleep routine, avoiding excess caffeine in the afternoons, avoiding too much physical exercise before you go to bed. So those are some really classic basic adjustments that people can do that can be helpful in setting a good foundation. And again, for people without true insomnia problems, you do those things, their sleep improves. For people with insomnia, it's good to have those in place, but you don't want to just leave all your time with doing sleep hygiene things.
So you alluded upon it. Are there different types of insomnia then?
It can come out in different ways, but more often than not, you get people that have all the above problems. So the difficulties with sleep initiation, fragmented sleep, and early awakening. I think in the assessment of a person's sleep problems, it's always important to rule out some of the medical issues that could be driving this, like restless leg, sleep apnea. Sometimes medications to treat one condition can create some other problems. But really the issue from a behavioral standpoint is how does insomnia get maintained? So what happens is we go several nights without sleeping. Well, what do? We start to crank up our caffeine, during the day. We start to go to bed at different times to try to get our sleep, or we wake up in the middle of the night and we watch TV to try to bore our brain to fall back asleep. So the irony is that efforts that we make to try to manage that daytime fatigue, or when we wake up in the middle of the night to try to get ourselves back to sleep or to try to keep going, throughout the day, actually very quickly become part of this conditioned problem over time.
And
Go ahead.
I was going to ask you about shift workers. How does this affect shift workers?
Yeah, this is an unfair, situation, but this is, very much one of these cultural, environmental factors that can make trying to get into a biorhythm of sleep and a sleep habit more challenging. It's not impossible when we work actually with a number of shift workers, especially nurses in our primary care clinics all the time with working on insomnia, but it makes it harder because any machine, any biorhythm works better when you have consistency.
What's the difference between primary and secondary insomnia?
Yeah, primary insomnia can be coming from some kind of medical condition. Secondary insomnia can be that learned pattern that happens over time. Again, in the end, for me, it doesn't matter. People can benefit from behavioral strategies in either case.
And I also see the phrase transient versus chronic insomnia. Is that kind of the same thing?
It's a time series, so I would say transient can be within that 3-month time window, or certain times of the year they may be more vulnerable to insomnia than others, whereas the chronic insomnia usually doesn't matter the time of year that they go through. It's just a persistent problem.
So you talked about the behavioral interventions at the beginning of the interview, and that's one of the things that's most helpful for people that suffer from insomnia. Let's talk a little bit more about that.
Yeah. So two parts of a behavioral intervention that are extremely important. So we already talked about getting the good sleep habits, under control. There's one behavioral principle called stimulus control. It's a very clunky behavioral term, but essentially it means reassociating the bed in the nighttime with sleep. And there's a number of different factors that actually go into that. So first off is developing a nighttime routine. So maybe a half hour, an hour before you go to bed, you start to reduce stimulation. You get the lights low, turn off the screens, turn off the TV, brush your teeth, get in comfortable clothes, and get into bed. This is not unlike how we teach our kids to fall asleep. This provides the brain with signs that sleep is coming. So doing that washout period is step number one.
And really, it's not just for kids.
It's not just for kids, it's for adults. We can't escape our basic biology.
Right. Very good.
Secondly is that once we're in bed, hopefully we fall asleep, but if we're in bed longer than 15 or 20 minutes, we actually want to get up and get out of bed. So we're trying to reduce the amount of wakeful time spent in bed. Sometimes people are given horrible advice. Hey, if you're in bed and you're not sleeping, at least you're resting. No, what you're doing is you're conditioning the brain to look at the bed in the nighttime with being awake. So what we actually get people to do is actually get out of their bed, go into another room, keeping it dark, keeping it quiet.
No TV.
No TV. Be in a sitting up position and do boring things. Like read something very familiar to you, listening to really light music, doing relaxation. And then when you start to feel sleepy, so your eyes get heavy, your head starts to bob a little bit, those are cues to get back into bed. Don't go back to bed when you're tired. Go back to bed when you're sleepy. And then if you fall asleep once you get back into bed, that's great. If you wake up again, keep repeating that cycle. And then one of the other things that we do as part of the stimulus control is reduce any wakeful activities in your bedroom during the normal wakeful day. So when your alarm goes off in the morning, get up, get changed and get out of the bedroom. Try to reduce hanging out in your bedroom, watching TV, eating, hanging out with the kids. It's kind of like getting out of the dorm room effect of our bed, is we don't want that to be Grand Central Station.
All right, 30 seconds to go. What about melatonin or other medications?
Well, if we think of prescribed medications, which has been the default treatment that's been done in primary care, realistically, they're only meant for short-term use, anywhere between 4 to 5, maybe in upwards of 6 weeks. However, the vast majority of folks that are on these medications use them for much longer. And we know clinically that they contribute to sleep problems actually as time goes along and lower quality of sleep. Melatonin melatonin has actually quite mixed results. As much as we like to think that it's a helpful intervention and reliably helpful, it's mixed results. It tends not to be harmful using it, but it also is not nearly as helpful as we'd like to think.
We've been talking about behavioral interventions to help treat insomnia with Mayo Clinic psychologist Dr. Craig Sawchuk. Thanks for joining us, Dr. Sawchuk.
Great. Thank you for having me.